Welcome to Pediatric Case Review. Today we'll be discussing diplegia in children, a form of cerebral palsy characterized by bilateral lower limb involvement. This comprehensive review is designed for medical professionals seeking to enhance their understanding of diagnosis and management approaches. Let's review our first case. A 2-year-old boy presents with delayed walking. The parents report a specific pattern in his movements. Which of the following would you most likely observe in a child with diplegic cerebral palsy? A. Uses a scissoring gait pattern. B. Has asymmetric movements favoring the right side. C. Shows tremors when reaching for objects. D. Demonstrates hypotonic posture. The correct answer is A. A scissoring gait pattern is characteristic of spastic diplegia in children. This occurs due to increased tone in the hip adductors, causing the legs to cross in a scissor-like pattern during walking attempts. Toe walking is also commonly observed as these children often have increased plantar flexor tone, which early developmental sign may suggest diplegia in an infant. A. Head lag at 6 months of age. B. Persistent fisting beyond 3 months of age. C. W-sitting position preference. D. Asymmetrical Moro reflex. The correct answer is C. Children with diplegic cerebral palsy often prefer W-sitting because this position provides stability for a child with poor trunk control and hip muscle function. This sitting pattern, while providing stability, can lead to orthopedic issues if maintained long-term. Other early signs include delayed rolling and commando crawling rather than typical quadruped crawling. During examination of a 3-year-old with suspected diplegia, which finding is most typical? A. Increased deep tendon reflexes in upper extremities only. B. Increased deep tendon reflexes predominantly in lower extremities. C. Decreased deep tendon reflexes in all extremities. D. Normal reflexes with isolated muscle weakness. The correct answer is B. In diplegic cerebral palsy, we typically find increased deep tendon reflexes predominantly in the lower extremities. This reflects the underlying upper motor neuron pathology. Spasticity, defined as velocity-dependent resistance to passive stretch, is the hallmark finding. Hyperreflexia with sustained ankle clonus is common, while upper extremities may show mild involvement, but to a lesser degree than lower limbs. A 5-year-old with diplegia undergoes spasticity assessment. Which scale is most commonly used? A. Wong-Baker-Faces scale. B. Glasgow-Coma scale. C. Modified Ashworth scale. D. Manual muscle testing scale. The correct answer is C. The modified Ashworth scale is the most commonly used clinical measure of spasticity. It grades resistance to passive movement on a scale from 0 to 4, with higher numbers indicating greater spasticity. Though somewhat subjective, it remains widely used in clinical practice. Other important assessments include the Tardieu scale, which accounts for velocity of movement, and the gross motor function classification system, which categorizes overall functional abilities. A premature infant born at 28 weeks develops diplegia. Which brain structure is most likely affected? A. Basal ganglia. B. Cerebellum. C. Periventricular white matter. D. Thalamus. The correct answer is C. Periventricular white matter injury, specifically periventricular leukomalacia, is the most common cause of diplegic cerebral palsy in premature infants. The corticospinal tracts that control the lower limbs pass through periventricular regions. The fibers controlling the legs are positioned closer to the ventricles than those controlling the arms, explaining why lower extremities are more affected in diplegia. Which factor carries the highest risk for developing diplegic cerebral palsy? A. Maternal diabetes. B. Premature birth before 32 weeks. C. Prolonged labor. D. Post-term delivery. The correct answer is B. Premature birth before 32 weeks gestation carries the highest risk for developing diplegic cerebral palsy. The risk is inversely proportional to gestational age, with extremely preterm infants having the highest risk. Other significant risk factors include intraventricular hemorrhage, hypoxic ischemic events, and multiple births. Maternal diabetes primarily increases risk for other birth complications rather than being a direct risk factor for diplegia. A 15-month-old presents with developmental delay and suspected diplegia. What is the most appropriate initial neuroimaging study? A. CT scan. B. MRI brain. C. PET scan. D. Ultrasound of the brain. The correct answer is B. MRI of the brain is the gold standard for neuroimaging in suspected cerebral palsy, including diplegic forms. MRI can clearly visualize periventricular white matter injury, the most common underlying lesion in diplegia. It also helps exclude other conditions that may mimic cerebral palsy. CT scans expose children to radiation and provide less detailed information about white matter abnormalities. Ultrasound has limited value beyond the neonatal period. A 2-year-old presents with progressive spasticity in the lower limbs. Which investigation should be prioritized? A. EEG. B. Metabolic screening. C. Genetic testing. D. Spine MRI. The correct answer is D. Spine MRI should be prioritized in cases of progressive spasticity. True cerebral palsy is a non-progressive disorder, so progression of symptoms is a major red flag suggesting an alternative diagnosis. Spinal cord pathology such as tethered cord syndrome, spinal tumors, or transverse myelitis can present with bilateral lower extremity spasticity mimicking diplegia. Other concerning features include sensory changes, pain, or bladder and bowel dysfunction. A 4-year-old with diplegic cerebral palsy has increasing difficulty walking due to spasticity. What is the first-line pharmacological treatment? A. Botulinum toxin injections. B. Oral baclofen. C. Phenol nerve blocks. D. Diazepam. The correct answer is A. Botulinum toxin injections are typically considered the first-line pharmacological intervention for localized spasticity in children with diplegic cerebral palsy. They provide a targeted approach with fewer systemic side effects compared to oral medications. The effect is temporary, lasting 3 to 6 months, which requires planning for follow-up injections. For optimal functional outcomes, botulinum toxin must be combined with physical therapy and often orthotic management. Which physical therapy approach is least appropriate for a child with diplegic cerebral palsy? A. Constraint-induced movement therapy. B. Gait training. C. Stretching and range of motion exercises. D. Strength training for core and lower extremities. The correct answer is A. Constraint-induced movement therapy is primarily designed for children with hemiplegia, not diplegia. It involves constraining the less affected limb to force use of the more affected side, which isn't applicable in diplegia where both sides are affected. Appropriate physical therapy for diplegic cerebral palsy includes stretching to maintain range of motion, strengthening exercises for core and lower extremities, and gait training. Evidence shows goal-directed, task-specific training is more effective than passive approaches. A 6-year-old with diplegic cerebral palsy has worsening crouch gait despite conservative treatment. Which surgical intervention might be indicated? A. Tendon transfers. B. Selective dorsal rhizotomy. C. Deep brain stimulation. D. Corpus callosotomy. The correct answer is B. Selective dorsal rhizotomy is a neurosurgical procedure that can significantly reduce lower limb spasticity in carefully selected children with diplegic cerebral palsy. The procedure involves selectively cutting dorsal rootlets that contribute to abnormal muscle tone. Ideal candidates have pure spasticity without dystonia, good underlying strength, motivation, and access to intensive rehabilitation. It's important to note that orthopedic procedures may still be needed to address fixed contractures, and long-term intensive physical therapy is essential after rhizotomy. A 3-year-old with diplegic cerebral palsy and equinus gait would most benefit from which orthotic device? A. Supramalleolar orthoses. B. Hip abduction brace. C. Ankle-foot orthoses. D. Knee-ankle-foot orthoses. The correct answer is C. Ankle-foot orthoses are the most appropriate orthotic intervention for a child with diplegic cerebral palsy presenting with equinus gait. AFOs control ankle position, prevent equinus, and improve overall gait efficiency. They come in several designs, including solid AFOs for maximum control, hinged AFOs to allow controlled dorsiflexion, and dynamic AFOs that store and release energy during gait. Orthotic management should be integrated with physical therapy and regularly reassessed as the child grows and develops. An 8-year-old with diplegic cerebral palsy reports increasing hip pain. The most concerning complication to evaluate is A. Growing pains. B. Hip subluxation or dislocation. C. Osteomyelitis. D. Juvenile arthritis. The correct answer is B. Hip subluxation and dislocation are common complications in children with diplegic cerebral palsy, with prevalence ranging from 25 to 75%. This occurs due to muscle imbalance with spastic hip adductors and flexors overwhelming the abductors. Hip pain often indicates progressive displacement. All children with diplegic cerebral palsy should undergo regular hip surveillance with clinical examinations and radiographs. Early intervention for hip displacement is critical to prevent painful dislocations that may require complex reconstructive surgery. A 5-year-old with diplegic cerebral palsy presents with poor weight gain and frequent respiratory infections. Which associated condition should be suspected? A. Dysphagia. B. Attention deficit hyperactivity disorder. C. Seizure disorder. D. Visual impairment. The correct answer is A. dysphagia or swallowing dysfunction is an important comorbidity to consider in a child with diplegic cerebral palsy presenting with poor weight gain and recurrent respiratory infections. While upper extremity function is less affected in diplegia compared to quadriplegia, oropharyngeal muscle function may still be impaired. Swallowing difficulties can lead to aspiration, malnutrition, and recurrent pneumonia. Management requires a multidisciplinary approach, including speech-language pathologists, nutritionists, and gastroenterologists to optimize feeding safety and nutritional status. Which factor is the strongest predictor of independent ambulation in a child with diplegic cerebral palsy? A. Intelligence quotient. B. Ability to sit independently by age 2. C. Presence of epilepsy. D. Socioeconomic status. The correct answer is B. The ability to sit independently by age 2 years is one of the strongest predictors of eventual walking ability in children with diplegic cerebral palsy. This developmental milestone indicates sufficient trunk control and balance for potential ambulation. Other positive prognostic factors include milder spasticity, absence of seizures, and higher cognitive function. The gross motor function classification system level at age 2 is highly predictive of long-term functional capabilities, with children at GMFCS levels 1 and 2 having the best prognosis for independent ambulation. Thank you for joining our comprehensive review of diplegia in children. Remember that early diagnosis and intervention are crucial for optimizing outcomes. A multidisciplinary approach involving neurologists, orthopedists, physical therapists, and other specialists provides the best care for these children. Please subscribe to Pediatric Case Review for more educational content on pediatric conditions, and leave your questions or suggestions in the comments below. We appreciate your support in our mission to improve pediatric care through education.